Hi and welcome back to my channel Small Kids Big Emergencies. I'm Dr. Carl, a paediatric emergency medicine doctor, and today we are looking at the last part in our series on eating disorders in kids. Today we're going to look at how big a challenge is this and some top tips for addressing this challenging set of disorders. Like a shark, on the surface it may appear to be a small issue, but when we look beneath the surface we begin to understand the scale of this problem. In the last decade, hospital admissions for eating disorders have been skyrocketing. Let's take a minute to listen to a news story from 2022.
I wasn't worth treatment, as though somehow it reflected my sense of self-worth.
Walking with James, it's easy to see how years of being ignored have affected his adult life. He developed anorexia as a teenager, but no one knew how to help him.
I think one of the reasons why I still struggle with bulimia now is because it took so long to get specialist help. I was diagnosed when I was 15, but it wasn't until I was 21 that I got specialist help, and it wasn't that I was just mildly ill. I was seriously unwell, in and out of hospital during that time, and the approach was just to sort of patch me up and send me back out.
Lockdown has made James's condition worse, and he's now waiting for more treatment. But waits can often lead to more hospital admissions. In 2015, there were just over 13,000 admissions for eating disorders such as bulimia and anorexia. In 2020, those numbers increased by 11,000, a rise of 84%. The number of boys and young men being admitted over the same period went up by 128%.
There was a significant pressure on NHS services pre-pandemic. So the impact of the pandemic has been really devastating on those already very much in demand services. So I think now what we're seeing is people who have become increasingly unwell during that period. So we've had this sort of acceleration, if you like, that I think we're seeing, and the numbers obviously that we're talking about today demonstrate.
It's why new guidance has been written for all healthcare workers to ensure they spot those who need help early.
When they come into the emergency department very sick, and they don't go to the psychiatric wards, they go to medical wards because they're so sick. And so the physicians who are looking after them have not been educated in how to manage.
James is grateful of the new guidelines and feels lucky he didn't fall through the gaps, but worries without it, thousands of others may not be so fortunate.
Subsequent to these events and eating disorders hitting the news, there has been an increasing research focus on the extent of the problem. Let's now hear directly from one of the clinical researchers who was talking at the Royal College of Paediatrics and Child Health conference. Aside from the impact on healthcare and hospitals, we must of course put our patients center and remember the impact that is occurring for children, families, on homes and upon school communities. Furthermore, caring for patients with eating disorders profoundly impacts hospital staff, often causing high levels of emotional distress, physical exhaustion, and frustration due to the demanding nature of treatment. staff, particularly in emergency and general settings, often feel undertrained and face challenges managing patients who may challenge authority or resist treatment. Effective care for eating disorders depends on collaboration, not hierarchy. When clinicians work closely with patients and families, sharing expertise, listening to lived experience, and aligning goals, they build a clearer picture of the illness and a stronger foundation for recovery. In conditions where trust, motivation, and daily support matter deeply, partnership turns treatment into a coordinated effort that is more responsive, humane, and ultimately more effective. So why do eating disorders continue to get missed? Why are they so elusive? First of all, many staff have a lack of training. A recent survey found that only 2% of emergency staff receive dedicated eating disorder training. 2, there are many biases, prejudices, and misconceptions around eating disorders. Patients with eating disorders often do not fit the classic thin, emaciated phenotype. Eating disorders occur across all genders, all races, all body sizes, and all socioeconomic groups. And then lastly, patient factors such as denial, shame, and the lack of insight are common. Patients with anorexia often have little or no insight and may deny their symptoms. We must overcome our fears and ask about eating issues. Consider eating disorders as a reason for vague complaints. Consider taking collateral histories. Have suspicion, even in circumstances where children appear active and well. Do not be falsely reassured by well-looking children and young people. Do not be falsely reassured by normal blood results. If the clues are there, take attention to them. Reassuring or dismissing children with low risk features is also a pitfall. If they are early on in their disorder, such reassurance can reinforce the disorder and cause them to think that change isn't necessary. Of course, communication is also important. Think before you speak. Don't talk loosely about diet, weight, or shape. You may cause harm without knowing it. Avoid fat talk and avoid making unrealistic promises. Avoid unreasonable changes that accommodate the disease. However, stay kind and caring for the person. It can be frustrating at times when managing these illnesses. At all times, avoid criticism and hostility. Don't be secretive. If progress is poor, say so. Be transparent and be honest. Be strength-focused. This includes when speaking about the family. Words matter. Indeed, it is easy to stereotype, to blame, to make assumptions. We are designed to simplify things, but the truth is often more complex. Remember, not all people with eating disorders are young. Not all are women. Eating disorders impact all groups. They can occur with or without previous trauma. People with these conditions do not always look skinny and near collapse. The person may look well in front of you. Do not have a blanket approach. For example, do not do daily bloods on all patients. Patients at risk of refeeding do not require daily bloods unless they are at high risk. twice a week is often adequate for lower risk patients. Also, take care with instructing bed rest. Complete bed rest can be detrimental to some patients and can cause muscle wasting and pressure sores. We're now going to look at some difficult scenarios. Case 1. What do we do if the patient strongly resists treatment? Fortunately, this is rare, especially if the patient is severely unwell. It is more common, however, when they are less unwell. Remember, be compassionate. Food can be terrifying for the patient because of the intense feelings engendered by the eating disorder. These situations can be challenging to manage, particularly in the acute setting. Take the following approach. Try by starting to help the patient understand the need for nutrition. Offer choices about the types of food or supplements. Involve a dietitian's experience in helping with eating disorders. Employ expert nursing support. Distraction strategies can be helpful to reduce anxiety relating to eating or fear of weight restoration. Provide psychological support, not only to the patients but to the team caring for them. When managing young people or older people with eating disorders, consider the possibility of comorbid autistic spectrum disorder. Sensory aversions need to be acknowledged. Oral supplements in tablet or liquid form may, for example, be difficult. As ever, restraint is an absolute last resort. Treatment against patient's consent should only ever be done within an appropriate legal framework, such as the Mental Health Act or equivalent legislation, and only by staff trained in control and restraint techniques. If the person is high risk for their eating disorder and at risk of refusal or absconding, consider in advance 1. Contacting a psychiatrist as soon as possible for advice. 2. Considering what mental health legislation might apply early on. 3. Utilizing the Mental Health Act. Getting the doctor in charge so that they might be able to prevent the patient leaving Medica legally for up to 72 hours. Remember de-escalation strategies the whole time. Use your team, including security, but do so gently. The use of the Mental Health Capacity Act to prevent a patient leaving is rarely justified in children. Parental consent, on the other hand, can be potentially useful to enforce treatment, and the use of the Mental Health Act is always preferred. Okay, so what about the scenario where a child with a diagnosis of an eating disorder does not want their parent to know? Remember, you're not legally able to give out information about the patient to their parents if they express this wish and they are over 18. Explore why the patient is concerned about sharing information and think about which relatives are able to give information but avoid providing those relatives with information. You can take information, but it is not appropriate to give out information. Okay, so what about those kids between the ages of 16 and 18? Here it is legal for staff to give information to parents if they can show that the provision of information is in the patient's best interests and lies within the zone of parental responsibility. Given the pervasiveness and chronic nature of many eating disorders, this may well apply. And how about those under 16? A child has the same right to confidentiality as an older patient. However, whilst the patient can accept treatment if they are Gillick competent. They cannot decline treatment deemed essential. In such cases, parents therefore need the information necessary to justify and make treatment decisions on the child's behalf, exercising their parental responsibility where the primary concern is the child's welfare. To finish, let's consider a few take-home points. First, discharge versus admission. Essentially, there are 4 key considerations to have in mind. Vital signs. Is the heart rate below 50 in the daytime or below 45 at night? Are orthostatic vitals acceptable? Is there a change in systolic blood pressure that's greater than 20 or a change in heart rate that's greater than 30? Electrolytes. What's the potassium? What's the phosphate? Acute food refusal. For example, has there been no intake for more than 48 hours? And weight loss. Has there been a loss of weight that's greater than 10% in 6 months? Or is the child's median BMI less than 75% right now? Again, remember, avoid dismissing vague symptoms. Do not make assumptions about risk based on heart rate. Do not be reassured by normal lab results. And always screen for comorbid suicidal ideation. Special thanks to Hampshire CAM's YouTube channel and EM Cases from Toronto for their inspiration. For further learning, do visit the Beat Eating Disorders website and have a read of the guidance on recognizing and managing medical emergencies and eating disorders. Thank you so much. Consider following and subscribing to Small Kids Big Emergencies, and I look forward to speaking to you next time.